Okay, thank you for being here. My name is Eric Kleinenberg. I'm a professor of sociology and also the director of the Institute for Public Knowledge, along with the university's cross-cutting initiative on inequality. IPK wanted to organize a series of events where people in our community have a chance to learn more about various aspects of the pandemic that we've lived through over the last year. And as it happens, NYU is a massive institution with many different schools. There are a lot of people here who've been working on the pandemic, from a very distinctive perspective, who don't often have a chance to put their ideas together. And so our baseline goal for the series that we've organized is to try to get some people in the schools speaking to each other and fertilizing research projects that will be greatly improved by cross-disciplinary collaboration. Our more ambitious idea is when there's a kind of a real trauma, consequential event, we think the university has a role to play stepping up and helping everyone, students, faculty, staff, and people who are in the wider university area, figure out what's going on, make sense of the situation, try to process what we've experienced together and figure out what the lessons are, parts so we can do it better next time. And we very much hope that this series does it. This is the first of 5 different events that we'll have on Thursday afternoons at this time, on a range of themes, including health disparities, which is our topic for tonight, questions about the future of public goods, questions about the post-pandemic city, issues about the pandemic and protests that have been happening over the past year and how those are related. We're really just delighted to have you as part of this conversation, so thank you for being here. The format for tonight is that we've asked each of our speakers to speak for about 10 minutes just to set up the conversation. I might ask a follow-up question here or there, but the goal is to have each of them speak for 10 minutes, then to bring them into conversation, and then to give you some time to ask questions. And we aim to be just about an hour tonight, so you can all go home or at least move from your bedroom into your living room at 6 p.m. I should also say, we're very lucky to have a terrific set of speakers throughout the series, and I'm especially thrilled about tonight. We have speaking first, Melody Goodman, who's an Associate Dean for Research and also Associate Professor of Biostatistics at NYU's School of Global Public Health. Dr. Goodman does applied biostatistical and survey research to try to advance community-based intervention and health disparities research. She's very interested in kind of figuring out issues of measurement, which are so important in all scientific research, but of course have real significance when we're dealing with health and medical issues. She's done academic and community collaborations. She implements, evaluates, and enhances the infrastructure of community-engaged research on health disparities. She has support from the National Institutes of Health, the Robert Wood Johnson Foundation, the Verizon Foundation, and many others. We're delighted to have Melody at NYU and excited to see the kind of projects that she builds as she helps the university do more focused work on health disparities. After Melody, we have Chow Trinh Chevron, who's a professor of population health and medicine and also vice chair for research in the Department of Population Health at the NYU Grossman School of Medicine. Working with academic and community partners in New York City, Dr. Trinh Chevron founded and established NYU's Center for the Study of Asian American Health in 2003, a National Institute on Minority Health and Disparities National Center for Excellence at the NIH. And I'm really excited to have Dr. Trinh Chevron in conversation with those of us in the social sciences who are very concerned with these same issues, but who have not had the same level of engagement with the medical school that we probably should have. And finally, we have Jacob William Faber, who's associate professor at NYU's Wagner School of Public Service with a joint appointment in the sociology department. Jacob's research and teaching focuses on spatial inequality. He leverages observational and experimental methods to study the mechanisms responsible for sorting individuals across space. He has published a whole series of high impact articles on race and segregation and inequality in the US, and has been working with me on some COVID specific projects recently. Jacob is a graduate of NYU's Department of Sociology, and we feel really fortunate to have him on our faculty as well. So let me end there, and Professor Goodman, the floor is yours.
Thank you guys for having me. I'm going to, I think, start a good conversation by talking about health disparities among Blacks in America. And so I hope this really starts the conversation going a bit. Hopefully you can see my screen. So first, I just want to talk about what health disparities are. And so these are differences in health that are systematic and plausibly avoidable. They're influenced by policies, and they put socially disadvantaged groups at further disadvantage with respect to their health. The National Institutes of Health defines health disparities as differences in the incidence, prevalence, mortality, and burden of diseases and other adverse health conditions that exist among specific population groups in the US. And healthcare disparities has been defined as racial ethnic differences in the quality of healthcare that are not due to access-related factors or clinical needs, patient preferences, and appropriateness of intervention. So we know that in the US, particularly for Blacks, there's been disparities in diabetes, hypertension, stroke, asthma, overall death, and many other illnesses. I think one that is particularly stark is the disparities that we see in infant mortality, because these happen really early in life. But it was no surprise that we see disparities in the incidence, hospitalization rates, and mortality that have been attributed to COVID-19. And I'm going to talk about why that is a little bit. So I think we sort of all know that Black and Latinx populations have been hit the hardest when it comes to the incidence of coronavirus, at a rate of 1.5 and 2 times higher in many cases. This is an infographic that was developed by the CDC that basically shows you across racial and ethnic groups the disparities in cases, hospitalizations, and deaths. Each of these rates are compared to whites. We can have a conversation later about whether white should even be the standard, but this is sort of how people have been defining disparities. And so you can see that for Blacks, there's been disparities in the number of cases, hospitalization rates, and mortality. I think because data is so important, and because we've had so much missing data, and because we really didn't see disparities in COVID until they released data by race, it's really important to talk about data-driven approaches. And I love this quote from Bobo, who talks about the fact that data never speak for themselves. It is the questions that we pose and those that we fail to ask, as well as our theories, concepts, and ideas that bring a narrative and meaning to marginal distributions, correlations, regression coefficients, and statistics of any kind. And so I'm talking a lot about racial differences, and I want to be clear that when I talk about race, I'm talking about race as a man-made social construct, and that racial categories reflect social and ideological conventions, not meaningful natural distinctions. I really like Dr. Kamaris Jones' definition of racism because I think it really lends itself well to a public health framework. And so she defines racism as a system of structuring opportunity and assigning value based on the social interpretation of how one looks, which is what we call race, that unfairly disadvantages some individuals and communities, unfairly advantages other individuals and communities, and saps the strength of the whole society through the waste of human resources. You know, I think this point brings out the fact that there are genius in our ghettos, in our barrios, and on our reservations, and we really don't cultivate that in this country. And the idea that genius is equally distributed across racial ethnic groups, but it's opportunities that are not, and that's the differences that we often see. W.E.B. Du Bois has been talking about Black health since 1899, and I think this quote is so poignant because I think it still resonates today, that the most difficult social problem in the matter of Negro health is the peculiar attitude of the nation toward the well-being of the race. There have been few other cases in history of civilized people where human suffering has been viewed with such peculiar indifference. Just in 2020, in the New England Journal of Medicine, an article about racist policies as the root cause to US racial health inequalities said that change will require policies that restructure the chances for a healthy life for people of color, righting the wrongs done by the foundational racial hierarchy that continue to shape everyday life. So we've been talking about and studying and building sort of structures to address health disparities for a really, really long time. And I think Shawn Ridley raised an important question about, have we just created a new industry in America around eliminating disparities? And is this an ethical question now for us? And I think what resonates with me most is when you think about many of the current interventions that address health disparities are often colorblind. That is, that they provide individuals with immediate care, but they're not intended to address the broader racial factors that may undergird those disparities. So we know where you live has a big impact on the education you receive, the safety of your streets, and the social networks that you can leverage. And place really matters. Your geographic location determines your environment, your social environment, your physical environment, the built environment. And residential segregation is one of the many causes of health disparities. In fact, it is the structural linchpin that maintains structural inequality in the United States. Prior research has found associations between segregation and poor health status, poor birth outcomes, infectious disease, exposure to toxins, mortality, and health literacy. And what we know from public health is that your zip code is actually a better predictor of your health outcomes than your genetic code. And so social context really matters. And it's important that we use an interpretive framework to understand how people come to be exposed to risk or protective factors, and determine the social conditions under which individual risk factors are related to disease. I really want to go back to this point of residential segregation because it really impacts the differences in the social and physical environment that affect health outcomes. So I'm talking about social economic status, housing, education, quality jobs, safety, social networks, access to and quality of goods and services, and access to and quality of medical care. We know that communities of color have higher poverty rates, lower median incomes, poorer schools, older housing stocks, and lower home ownership rates. And so it's important that you understand that when I talk about segregation, I'm not talking about the fact that people of different ethnicities live close to one another. In fact, there's some evidence to show that ethnic enclaves are protective. The issue happens when different communities really have different potential to live a healthy life, right? And so in this instance, segregation is more than the physical isolation of people. It is the isolation from opportunity and opportunity structures that is the real issue. So in the 171 largest cities in the US, there's not even one city where whites live in ecological equality to Blacks in terms of poverty rates or single parent households. The worst urban context in which whites reside is considerably better than the average context for Black communities. Blacks are more segregated than any other racial ethnic group besides Native Americans, who we overtly segregate. Segregation varies by income for Latinx and Asians, but is high at all levels of income for Blacks. The wealthiest Blacks, defined as those making more than $50,000 a year, are segregated more than the poorest Latinx and Asians. Middle-class Blacks live in poorer areas than whites of similar SES, and poor whites live in better areas than poor Blacks. And Blacks show a higher preference for residing in integrated communities than any other group. So I talked a lot about segregation and its impacts on health, and I think it's really important to understand, particularly for Black Americans, that segregation in this country has been imposed by legislation. It has been supported by major economic institutions. It has been enshrined in the housing policies of our federal government. It's been enforced by our judicial system and vigilant neighborhood organizations. It's been legitimized by the ideology of white supremacy that has been advocated by the church and other cultural institutions. So it's sort of embedded in our US society. And so when you think about the idea that there are disparities in COVID, it makes sense because these things are sort of embedded in our society. And because I'm a professor, I always give a reading list. So For those of you who are sort of really interested in digging further into the things that I've been talking about, I think these are some great books. When Affirmative Action Was White, The Hidden Cost of Being African-American, How Wealth Perpetuates Inequality, The Color of Law, and How Racism Takes Place. Thanks.
Thank you. That's a terrific framing of the big picture situation that we're in right now, and really sets us up to dig into the specific crisis that we're living through. And I'm going to tap your brain a little bit later. I promise to ask you, how some of these issues have really hit home in New York and in other cities over the last year or so. But I appreciate that framing for a conversation. Dr. Trin Chevron, the floor is yours.
Thank you so much. Wow, Melody, that was such an excellent presentation, and the framework was terrific in really setting the stage about thinking about health disparities and where we're at, and how far we've come along and how far we have not, actually, in terms of that progress. So a little bit about the NYU Center for the Study of Asian American Health. That, as Eric noted, we were founded in 2003. We're among a dozen centers of excellence that are funded by the National Institute of Health, National Institute for Minority Health and Health Disparities. I think we were in this little box in Melody's very detailed table of some of the things that we have been used to help tackle health disparities. So the global pandemic, or the pandemic in the United States, has affected every facet of our life. And some of us have used the analogy that while we're all in the same storm, we're not all in the same boat. And for communities of color, particularly immigrant communities, the Asian American population is a largely first and second generation immigrant population. We're disproportionately affected by COVID-19 in a number of ways. Many of us are affected by the types of jobs that we live in. They're among low-income Asian American communities. Many of them are frontline workers. They're working in healthcare, they're working in hotels, they're working in restaurants, small businesses. They're out there in terms of serving communities on a day-to-day basis. Manhattan's Chinatown and Flushing, Queens were deeply devastated by what happened with respect to the pandemic in terms of not only consumer spending, but also being out there in the front lines. There's also a lack of affordable, equitable access to health insurance. We've seen that for many low-income Asian immigrant communities. And there's also a glaring absence of data for the Asian American population overall. We are tremendously diverse, and I'll talk about a little bit about that diversity in a moment. And so as being a largely first and second generation immigrant population, there are also a number of challenges related to language access that make it very difficult for a number of individuals who are experiencing limited English proficiency on a day-to-day basis, and even more complicated in terms of thinking about how do you navigate health information, understanding in terms of what are the ways to prevent or minimize the risk for COVID, what are the options in terms of COVID-19 testing, and even now thinking about COVID-19 vaccination. And then to complicate matters even more is the unique issues related to systemic racism that Melody also touched. And that is that, for Asian Americans, we have this issue of xenophobia and anti-Asian attacks that occurred in the last couple of years that were increasing in intensity, and particularly in the last year with the COVID-19 pandemic. Devastating in many ways. And I'm going to touch a little bit more about that in a moment. But first, just to give a little context for people who might not be familiar, the Asian American population in New York City represents about 1.2 million individuals, so 14% of the population of New York City. And we're extremely diverse. We hail from countries like China, India, Korea, Pakistan, the Philippines, Vietnam, as well as smaller emerging countries like Bangladesh, Bhutan, Nepal, and Sri Lanka. And with that diversity is also diversity in terms of languages, in terms of religion and different customs. All of that, plays in terms of thinking about sort of the social determinants of health, as well as the fact that, many of us are also among low-income communities may also gravitate or migrate towards ethnic enclaves. And sometimes these ethnic enclaves, the nature in terms of the affordability of living in New York City are, in the poorest areas of New York City, medically underserved. There's often double or tripling of occupancy rates. So a number of challenges when you're thinking about differential capacity to shelter in place or to quarantine safely. And so, I think I would say fairly recently, more attention has been paid regarding COVID-19 disparities among Asian American population. I think it's been right that a large focus has been on COVID-19 disparities among Black and Latinx communities. The burden of those disparities have certainly been borne out in that way. But there have also been disparities among Asian Americans, as well as the smaller emerging communities like Native American populations that have only been recently been focused on. And we know that in October, the CDC reported that the average percentage increase in COVID-19 associated deaths among Asian Americans was about 36.6%. That was the second only to Hispanic persons in their population, in terms of the data set. Kaiser Permanente also released a report of their data examining their patient population and also revealed that Asian Americans had a higher risk of COVID disparities compared to their white patient population. But we also know in New York City and in California that the disparities exist. So my colleagues, Nadia Islam and Stella Yee, within the Department of Population Health, worked with a number of researchers from the Health and Hospitals, which is the largest public health care system in the United States. It's really the primary provider of care for many uninsured and underinsured New York City residents, serving more than 1 million New York City residents across the city. And so they examined the data of more than 85,000 patients that were seen in a health and hospitals facility between March and May of 2020. And in examining the data set, they also found that South Asians had the second highest rate of test positivity, nearly 31% following Hispanics, and also the second highest rate of COVID-19 hospitalizations at about 55%, second after African-American communities. They also found that Chinese Americans had a lower test positivity and hospitalization rates, but they also had the highest mortality rate due to COVID at nearly 36%, much higher than compared to other Asian American subgroups of which were at 26% and even higher than for African American populations at 24%. So really highlighting and underscoring the need to understand disparities among the Asian American population in a disaggregated way, to look at the data across subgroups, to really understand what are the challenges, what's the sort of the nature and magnitude of those disparities, and also understanding sort of the risk and protective factors that we need to think about. So clearly disparities with respect to access to testing, with respect to seeking care, differences across subgroups with respect to test positivity, hospitalization, and even mortality. And then the other thing that I had alluded to was the whole issue of the model minority myth that Asian Americans are all healthy, wealthy, and wiser. I think that stereotype has unfortunately done terrible harm for Asian American communities in terms of allowing focused attention and dedicated resources. We know that some subgroups have among the highest rates of limited English proficiency, so have some of the highest rates of poverty, uninsurance, and low educational attainment. All of those are factors with respect to COVID-19 disparities. But I also want to mention not only the physical health disparities that have been experienced among Asian American populations. From a community perspective, I think one of the most devastating components of this whole pandemic has to be the psychological trauma of xenophobia and racist attacks. It has resurfaced a number of issues. Historically, there's been the yellow peril, there's been a number of issues with respect to contagion and fear of disease and the blaming of immigrant populations, including Asian American communities. We know that Since March 2020, there's been more than 3,000 reports of anti-Asian hate incidents that have occurred. And we also know that these reports, most incidents are not reported. So those numbers represent an underestimate of what's going on. The New York City Police Department reported an 8-fold increase in hate crimes towards Asian Americans in 2020 compared to 2019. And so we believe that the stigma of being blamed as the community, the population that brought the pandemic to the United States, that has led that to other communities, has triggered all these issues, not only in terms of the anti-Asian attacks, but also stigma in terms of seeking testing, stigma in terms of going to the hospital. You know, why are Chinese Americans with COVID going to, more likely to die from the disease if they're hospitalized? They must be seeking care at a much later stage. And so, a number of things. I mean, it is gratifying to know that with the new administration, with President Biden, that he, within a week of his inauguration, signed a memorandum that disavowed discrimination and condemned racism, xenophobia, and intolerance towards Asian Americans. And so hopefully that will be a first step, but we know it's not going to be the only thing. There's still tremendous racism and stereotypes that are being perpetuated, and partly fueled in a sense by the fact that many people are afraid, and many people are hurting, with respect to this pandemic. But the community trauma needs to be also addressed, and that requires a really a multi-pronged approach in terms of what we need to do as a society in terms of thinking about not allowing such political rhetoric to occur among our leaders, and to also really enforce that, and working in concert with law enforcement and academic institutions and healthcare institutions to think about what are the ways that we can work together to reduce that kind of systemic racism and the violence that occurs in its aftermath. I also want to note again the social impact of this pandemic on Asian American populations. Asian Americans are disproportionately small business owners, and we have seen in Manhattan's Chinatown and in Flushing and in Jackson Heights that many of them were not able to secure government relief, in part due to language access. To be able to navigate the online forms, you had to be able to do it in English. You also had to be able to be affiliated to a mainstream bank. For a lot of immigrant communities, the banks that they belonged to were not part of what was part of the paycheck protection programs. So I would say about 75% of small business owners that were Asian Americans were not allowed to access those resources. And that's probably the same for many other immigrant communities, including Latinx, Hispanic communities, in terms of being able to access that kind of government relief. We also know that food insecurity grew substantially for Asian communities living in these ethnic enclaves. Some of the neighborhoods, for example, in the Sunset Park area, doubled or tripled in terms of the food insecurity needs. So, communities where they have a substantial Asian American population. And then the final thing that I want to add too is that another interesting side effect of this pandemic is, our center really believes in the power of community health workers and working with trusted community organizations that have a relationship with many low-income, many immigrant communities. And they've always been an important part in terms of supporting social capital, fostering social cohesion, but they were tremendous during this pandemic, especially during the height of the pandemic, in terms of addressing needs with respect to food insecurity, medication deliveries, food deliveries, navigating access to both health and financial assistance when individuals lost their jobs or lost their businesses, overnight, in a sense, with the shelter-in policies, and also help to think about, many of our immigrant communities They often seek care from primary care from small provider practices that are also small businesses, but the small provider practices during this time were also terribly devastated by COVID-19 and shut down. And so many immigrant communities, many individuals lost total access to any kind of health care. Our community health workers and other community health workers that were serving immigrant communities were really that bridge to help facilitate access. So, that is certainly, with all that has come out from this pandemic and all that we do in terms of thinking about prevention of further health and social disparities, I think is to think about how do we leverage the community health workforce and support them in a way that is substantive to support pandemic preparedness, as well as prevent, the further emergence of other health disparities. And I'll stop here.
Thank you. That was really an eye-opening presentation. And I especially appreciate how you helped us think about this disease and the specific impact it had on Asian American populations in New York, but also all the kind of ripple effects and the other sources of trauma in addition to the acute health distress. We're so focused on the total number of cases and the mortality, which of course are massively significant, that I think it's been easy to forget about all the associated forms of trauma that different communities in New York have experienced. And you called attention to the spike in ethnic and racial discrimination, which obviously facilitated by political leaders and major media that were eager to talk about the China virus, and it seemed as if they were actively trying to stir up racial resentment. But also you talked about the repercussions for small business owners and for health workers and members of the community who will be affected long after we reach herd immunity. I think that's the real implications of this event for the life of this country and the city. And I definitely want to return to those issues later. Before we get there, one quick announcement for everyone. When Professor Faber's done with his presentation, we'll be opening up for questions. So if you could scroll down on your Zoom screen, there's a Q&A feature there. I'm just going to ask everyone to please write your questions, and we'll take as many as we can. Professor Faber, your turn.
Right. Let me mute myself. You can hear me, right?
You're a little muffled.
Okay. Is this better?
A little better.
Okay. Thanks, Eric, for organizing this, and thanks everyone for coming, and thanks Chow and Melody for those really great presentations. Both of you covered several things that I had planned to, so I kind of made some edits to this on the fly, which is good because I'll talk for less time. Melody, so I think what I want to focus on in my kind of 10 minutes here is the extent to which this crisis and the really just depressing racial inequality and how it's played out, both of which both of these things were incredibly predictable, that they were almost inevitable given the our history. So Melody already talked about the racial disparities in COVID exposure and death. Another kind of sad way to look at this is on the impact in life expectancy. And life expectancy on average for the United States fell by an entire year in between 2019 and 2020. The last time it had fallen this far was World War II. And of course, more people have now died from COVID-19 than died during World War II. And unsurprisingly, given the racial disparities in COVID-19 exposure and death, differences. There are enormous racial differences in this decline of life expectancy. The fact that non-Hispanic Black males lost 3 years of average life expectancy in a 1-year time period is really a pretty terrifying thing to think about. And Chow mentioned this, and as did Melody, that the kind of economic consequences of the pandemic were also disproportionately felt by people of color, primarily African Americans and Latinos, who saw their, this started out with higher levels of unemployment before the pandemic, but saw much larger and much longer sustained increases in those in unemployment. There's a kind of growing body of research, as my cat joins us here, connecting segregation to the kind of direct impact of the recession, including this very new paper by Gerard Espinosa, another NYU alum, showing that counties that are more segregated had much higher rates of mortality. And there are a million mechanisms connecting racial geography to racial inequality and COVID. We can think about housing that's been mentioned already, crowding and multi-generational housing, exacerbated by evictions and foreclosures during the pandemic, employment and wealth, occupational segregation shaping the ability of individuals to work remotely, take time off work, and flee hotspots, environmental and health, kind of shaping the distribution of underlying health conditions as well as access to care, and social networks through which information disseminates, and also in a concentration of exposure is exacerbated. And as Melody said, the segregation that we see today was intentionally constructed in large part by the federal government through New Deal era housing policies, but also through many state and local government actions, as well as private actors, as Melody mentioned. Here we see one of the infamous redlining maps of the Homeowners Loan Corporation, which were drawn by appraisers during the New Deal, shaping opportunity to buy housing and accumulate wealth for a generation and in a highly racialized way. A recent paper of mine kind of directly connects the practice of redlining to contemporary levels of segregation, showing that it definitively increased segregation, but it also increased housing quality, which is another kind of exacerbating factor of in the pandemic. I don't really need to kind of go through the entire history, of course, of American housing policy, but it's important, of course, to note that, again, there were these massive federal housing programs that created the contemporary homeownership society, helped millions and millions of primarily white Americans, in some cases almost exclusively white Americans, buy homes in white neighborhoods, kind of funneling money out of urban communities of color into suburban white enclaves. And as homeownership was kind of opening up for white individuals in white neighborhoods, of course, we were kind of building segregated public housing and using highways to segregate and urban renewal to displace people of color. And over the time, this kind of conflation of race and home value and lending risk constrained housing options for people of color, creating opportunities for exploitation through practices such as block busting. And again, kind of over generations, this pulled people and investment out of cities and into predominantly white suburbs. And there's also research showing that within cities, the practice of redlining also led to racial concentration within neighborhoods. If you kind of look at COVID directly, This is work that I haven't really shown anyone yet, but the grades from these redlining maps are strongly correlated with COVID for fatalities. That places that were rewarded for being white and wealthy in the 1930s and 40s are that privilege was concretized by these housing policies. And while we're talking about multi-generational vulnerability, we have to talk about how COVID was this quintessentially American political failure, because the structural disenfranchisement caused by segregation, again, as Melody mentioned, is not just because Black people live over here and white people live over here, but it's because of the layers of policy and politics that distribute opportunity geographically as well. And when it comes to COVID, we have to talk about the politics of anti-science that the Republican Party has been engaged in for over half a century, as we look at several House Republicans who refuse to wear masks when sheltering from the assault on the Capitol on January 6th with their Democratic colleagues, several of whom got ill because they were sheltering with people who refused to wear masks. And of course, this has connections to climate change denial, attacks on the census, and my own field of social science. And this is connected to our ideologies of individuality over collective good. And really what we saw over the course of the last 10 months or so is really just grinding laborers into this machine of capitalism rather than prioritizing safety. And the callous and neglectful response to early hotspots in blue states and in communities of color, of course, is another reflection of this reality, of this politics. So, just to wrap up here, just a few closing thoughts. When we think about policy, we should be asking questions about how can recovery be not just equitable but reparative, and of course, how can we prepare for the next epidemic? I really appreciated Melody's talking about the inequality industry. That there's a lot of talk and investment in short-term interventions, but rarely is there focus on these underlying multi-generational structural determinants of racial inequality. And for social sciences scientists, there are, of course, questions about the individual level impacts of this pandemic, but as we're seeing throughout this crisis, neighborhoods matter too, as social units, and have been devastated, especially communities of color, especially immigrant and ethnic enclaves. So I think I'll stop there, though. I'll do one more fun statistic about the inequality in the recovery. Of course, is racial inequality in access to the vaccine. So thanks, and I will unshare my screen and look forward to this conversation.
Thank you, Professor Faber. I'm glad we ended there on the vaccine story, because of course that's a kind of continuation of this theme, that the zip codes in New York City where we saw the greatest health disparities, that had the highest rates of mortality, had been ranking very low in terms of vaccine access, and the neighborhoods where people had the best access to good health conditions during ordinary times and had low COVID fatality rates, unsurprisingly, have had the best access to vaccines. So that contradiction emerges once again. There are a lot of structural stories about inequality that we've been discussing that I think we all feel they're probably not surprising to anyone on the panel. Like if I had asked each of you to predict what would happen in the pandemic, I'm guessing you would have predicted the pattern that would play out in this way, particularly since it's, the kind of first cases that were announced came from Wuhan. There's a lot about this that has been predictable for social scientists and for epidemiologists and health scholars. They probably don't get enough attention in the larger public conversation, of course, but they're not surprising. What I wonder if from each of you is if there have been any trends that you were not expecting, at any scale. Have you been surprised by anything that we've seen in the course of this pandemic? So, for instance, are there, certain cities or neighborhoods that demographically seem like they'd be very vulnerable that turned out to be, to do better or to do worse? Are there systems that have been more effective than you would have thought? Parts of the story that from a health disparities perspective, you think we should be focusing on because they could help us learn? And anyone can take that question.
I have not been surprised by much over the past year, but the one kind of, as a kind of housing and segregation scholar, Eric, have talked about this offline, but one interesting kind of finding from people who have looked at neighborhood level predictors of COVID is that density is not a very strong predictor of COVID, but crowding is. And some of that has to do with the fact that in places like New York City, the densest neighborhoods are often the wealthiest, so people are able to kind of protect themselves with privilege, but also, of course, as Chow mentioned earlier, the kind of housing quality in communities of color, the kind of dependence on multi-generational housing and doubling up with friends and family shaped exposure in a way that was kind of separate from just density.
Anyone else want to take that?
I guess I would say the positive thing that I don't think we focus on enough is how fast a vaccine has become available. Just where we were in terms of science, I don't think we've really appreciated enough that we had advanced science enough that something that normally takes 5-10 years sort of happened really quickly. And also how effective they are, right? Like not just that we were able to create them, really quickly, but that the data suggests that they are really effective. And so while there's disparities in who gets it, and we can talk about all those issues, I just think that the yay for science is our ability to have moved on this so quickly and have been so successful.
I think that's right. It's been interesting to see that the production of the vaccine was one part of the story. The distribution was another, and just an amazing transformation in the way that the federal and state governments began to act on distribution with the new administration. It was kind of extraordinary, jaw-dropping to see that there wasn't really a plan to get it to people before then. We've really seen how political leadership matters in both good and bad ways, I think, in this event. Did you want to add something?
Yeah, I just, the only a few things I wanted to add that, it's interesting about the COVID-19 pandemic that it mirrored and magnified historical and ongoing social and health inequities for the communities that are persistently, confronted by it. And so it's certainly that from a historical context and to think through, what are the lessons learned? And I think too that, now that we've have moved to the stage of having these vaccines that are powerfully effective, and the potential for the mass rollout it very quickly, and probably in weeks to come with all these, with the increased supply, in the conversations that we've had with other colleagues like Aisha Langford at in the Department of Population Health, who has taught me and many others, a little bit more about understanding vaccine hesitancy and understanding the whole continuum of what makes individuals vaccine hesitant or and that span, but also really appreciating that we, as much as we want to pay attention to some of the strategies to reduce vaccine hesitancy, we also need to be very careful that the strategies that we employ are not individually focused, that we don't blame certain communities, and that the way that we want to ensure that everyone is getting access to these vaccines, that we really want to think about how do we take an equity approach. We are hearing from our community partners that on the ground, more and more racial and ethnic communities in some of the low-income communities that we serve, there is more acceptability, and they do want to have access to the vaccines. The greater obstacles lay in misinformation, in knowing who's eligible, when you're eligible, and being able to navigate those online sites. And it's all dependent on whether or not you have access to a stable internet service, or having a computer, or if you're not experiencing language barriers. And then we're also hearing from our FQHC, our federally qualified health center partners who serve low-income communities, that the people who are coming in for vaccine appointments aren't from those neighborhoods. And so thinking about how do we ensure equity in terms of access, I think that is like the next struggle or the next challenge for us in terms of really thinking through how do we reduce, further disparities that might occur with this increased vaccine access.
This is a great point. And one of the things that I'm also struck by is the speed with which some cities and states have dealt with that specific problem. I don't know how much people have been following the vaccine rollout, but in the last few days, the city of New York has been designating vaccination sites for people with specific zip codes. And you're only able to get vaccinated if you show ID with those zip codes on it. And that turns out to be a much more effective tool than just setting up a vaccination center, in a place, right? So we saw all those reports on vaccination sites in the Bronx being, filled up with people from Westchester or upstate. But I am impressed by the ingenuity of the city for dealing with that situation. I'm very hopeful that as more vaccines come online, we can get more people vaccinated quickly. And my understanding is that a lot of the skepticism that we've seen from communities of color, who we all acknowledge have every reason to be concerned about the way they're treated in these kinds of situations, is I think starting to wane. And there's real interest in getting vaccinated. So let's keep our fingers crossed on that. I wanted to ask you, Dr. Trin Chevron, a question. At some point in the pandemic, I saw some data showing that despite conditions that have a lot of crowding, despite a lot of essential workers, that at some point the mortality in Flushing was considerably lower than some of the other areas in that part of Queens. And I heard some speculation that there were social networks in New York's Asian American communities that got activated earlier than in other places, that there are enough ties between Chinese American or Korean American communities in New York and people in China or Korea, that the kind of warning systems came into place, and people were getting masks and were taking seriously kind of being indoors, whereas that information didn't travel through other ethnic networks in the same way. I'm wondering if that's an idea that people are considering. What do we know about social networks and the way that they've operated during this time?
Well, thank you for asking that question. So that is part of one of the great lessons that we've learned too, is the power of the community health workers and these community organizations in helping to be there and really be a key part of this whole pandemic response for the Asian American population. We in March and April, immediately many of our partners reached out to us needing in language materials, working with us to do these workshops. And then having our community health workers redirect and work with their community organizations to be able to address those. It was an intensive all out effort that I don't know what was being done for other communities, but I definitely can say that for the immigrant communities that were from Chinese or the Korean or South Asian communities, many of the community partners and the community health workers that were employed with us and in other settings they were amazing in their response and amazing in helping to really create that inventory of resources to adapt the materials that were available in language, and then to be ready to support food deliveries and medication deliveries. And while they were doing that, imparting messages about risk communication, about wearing the mask and how to shelter in place safely, given the fact that, as you mentioned earlier, many of the communities they live in intergenerational households, with a grandmother, and so 3 generations in a household. And so we're thinking about how do we protect those members. And so certainly it was amazing to see them activated and to have those people to really call upon in that instances.
Thanks. Yeah. So we're just about out of time. Before we end, I want to ask one more question for Professor Goodman and Professor Faber. I wonder, you both talked about the impact of deep-seated structural issues around inequality and segregation for health. And there's no doubt that we're not going to be able to really redress these kinds of inequities until we deal with those deep structural issues. At the same time, we know that we're in an environment where we could have other pandemics. We could have other health crises probably before we're able to fix it. And I wonder if either of you see any lessons from the COVID experience, for what a government that wanted to deal with the threat of health disparities could do better, if something happens, before we fully desegregate America.
So I'm a biostatistician, so I'm going to say data matters. I think having the data systems and being able to collect data by race and place are really important. And I think we didn't have that in the beginning. And so if we had some sort of surveillance system that was set up that allowed us to do that at the beginning of a pandemic, I think then we can do more targeted type interventions.
Thank you. Jacob, you have the last word here. What's the magic bullet?
I mean, we did exactly the wrong things early on. So I think anything would have been better. But just echoing Melody's concern about data, I think the kind of implementation of that data is also really important. And believing scientists and driving policy with evidence is really crucial. And it also allows us to target marginalized communities.
Yeah. So I think we ended on a good note, especially a good one for given the university context of this conversation. I want to thank all 3 of you for taking time to participate in this evening's kickoff to our lecture series. Thanks to everyone who's watching and participating. In 2 weeks, on Thursday, March 11th, we have our next event on the pandemic and public goods, which features NYU faculty LaRue Lewis McCoy, Ingrid Gould-Ellen, Gianpaolo Bauchi, and Alex Barnard, talking about things like public housing and public transit and public health, public hospitals, public infrastructure. Really try to dig into this place where we left off today. What kinds of policy lessons can we glean from this experience so that we can do it better next time? Thank you all. I wish you all good health, and I hope to see you here in a few weeks. Good night.